Welcome to Grand Rounds. Today we have Dr. Caroline M. D'Ambrosio, and she's a pulmonary critical care and sleep medicine physician at Brigham and Women's Hospital of Harvard's Medical School. She previously served as Vice Chief of Fellowship Training in the section of Pulmonary and Critical Care Medicine, Associate Professor at Yale University School of Medicine, Program Director for the Harvard, Brigham and Women's Hospital Fellowship in Pulmonary and Critical Care Medicine, Associate Professor of Medicine at Harvard Medical School. She's a well-respected and expert in sleep medicine, as evidenced by chairing the Sleep Medicine Board Review course for the American College of Chest Physicians, serving on the editorial board of the self-assessment book Seek for Sleep Medicine, being the associate editor for Chest Pulmonary Journal for Sleep Medicine Content. She has received multiple teaching awards, such as Distinguished Teaching Award from the Pulmonary Division at Tufts Medical Center prior to her departure from there in 2014, Pillar Award for Educational Program Leadership, Top Award for Program Directors throughout Mass General Brigham institutions, Outstanding Educator for Yale University Medicine section of PCCSM. In 2023, she was also named the Outstanding Program Director and Medical Educator of the Year by Association of Pulmonary and Critical Care Medicine Program Directors. She has consistently been named one of Boston's best doctors for the past several years. Nationally, she has received numerous distinguished chest educator awards from the American College of Chest Physicians and is a member of the Board of Trustees for the Chest Philanthropy. In addition to her teaching and clinical work, Dr. D'Ambrosio has conducted research on sex and gender in lung diseases. She served as chair of the Women's Lung Health Network at the American College of Chest Medicine and has conducted research on sleep medicine and menopause, sleep and breathing in infants, and was a lead author on two important recent invited reviews on sex and gender influences in lung diseases. She has recently co-authored a book, Comfort the Kid, on infant sleep and parent bonding. Dr. D'Ambrosio will be leading discussion today on the topic of sex and gender influences in lung disease. Please help me welcome Dr. D'Ambrosio.
Thank you, everybody. And I truly appreciate being invited here today to speak to you about something that has been the hallmark of my career. I noticed very early in the 90s when I was in my training that we had learned an awful lot about men and not a lot about diseases and treatments in women. And so as my career has progressed, I've not only researched some of this, but I've made myself a self-described expert by reading the literature whenever I can. I have no financial disclosures to today's lecture. What we're going to do today is we're going to differentiate between sex and gender. You're going to learn the difference between those two terms if you haven't heard it already, and learn how that can influence lung disease specifically, and the outcomes of these lung disease, how they are impacted by patient sex or gender. So we'll start with some questions. I don't expect you to answer them, but think about them while I'm talking. What sex presenting with asthma symptoms is more likely to be prescribed psychopharmacologic agents rather than inhaled steroids? Between 2005 and 2014, what sex had the highest proportion of COPD hospitalizations and in-hospital deaths? Which cancer is the leading cause of cancer deaths in US women? And what sex is more likely to develop idiopathic pulmonary fibrosis? So let's go through this. We'll start out with our outline. We'll go over sex and gender. We'll talk about the background and the global burden of this area that we need to address. We have some information, but as you will see during this talk, so much more research is needed. And then we'll talk specifically about the influences of sex in asthma, COPD, interstitial lung disease, lung cancer. There are many more within the pulmonary area, but I decided to focus on these. So let's start off with our definition. Sex is a biological construct. It's biological differences. Gender is a social construct, physiologic and social differences. The NIH has put this together because the NIH has gotten on top of this now several years ago. And their definition is sex is a multidimensional biological construct based on anatomy, physiology, genetics, and hormones, sometimes referred to as sex traits. And we will talk a lot about the sex traits and sex hormones in some lung diseases. Gender is much broader definition. Multidimensional construct that encompasses your identity, expression, as well as social and cultural expectations about status, characteristics, and behaviors as they are associated with certain sex traits. And you can see down at the bottom the difference that NIH has put sex with these traits here, and then gender over here with these conditions. And so these are really important. So the way I think of it, the best example is if you look at traditional roles for gender roles, men have often been out in the workplace, farming, toiling the soil, working in factories, and women have traditionally been in the homes doing cooking. So what does that mean? Men might be exposed to certain inhalants in their work that cause lung disease. Women might be more exposed to something within the house, such as biomass fuels over a cook stove. Two different conditions that lead to lung disease. And the reason for the exposure was the person's gender and the expectations for that gender in that society. So the Federal Drug Administration has been on top of this for decades. They've had women and men, female males in clinical trials for a long time. The National Institutes of Health, it took them a bit longer. And in 2018, they put together an expert panel who really looked at this and decided that much more data was needed on how sex and gender influence certain diseases, and that and they came up with the sex and gender are biological variables that need more research. This is a big thing for people who are writing grants on human subjects or even not human subjects, even mice, et cetera, to really identify, are you going to look at this and why aren't you if you aren't? So let's talk a little bit about sex and gender, the global burden. Here's some background information. Sex composes of endogenous factors, sex hormones, which we'll talk about, and then reproductive events. For females, it's puberty, menarche, pregnancy, postpartum, and menopause, and these all can affect some lung diseases. Anatomical factors, lung size. Males have larger lungs, females have smaller lungs. Males have larger airway size, females have smaller airway size. That it comes to play in obviously in lung diseases. Physiologic characteristic, immune responses and endotypes. Genetics, the sex hormones, the sex-specific regulatory networks, et cetera, and then gene expression. For gender, it's societal things, right? So exogenous factors like socioeconomic status, education, environmental occupational exposures, smoking, access factors, access to care, health-seeking behaviors, preventative care. For those who do have access to care, I think we still are in a point where women go to the doctor routinely every year, whereas men don't necessarily do that. And so that is one of the differences between them. There's risk-taking behavior and then epigenetics, which comes into play as well. So for this big review that we did a couple years ago now, we did searches in PubMed on sex and gender and lung disease. And then we looked at sex and gender and heart disease. And in this chart, if you look here, the red is lung disease and the blue is heart. And from 1980 to 1999, our cardiology colleagues were way ahead of us. They're double the number of publications with that search engine. The next decade, same thing. And then our last decade, same thing. So the pulmonologists, we have a lot more work to do. We have a lot of diseases impacted by sex and gender. We just aren't there yet on publishing at the same rate as the heart disease specialists. This is a great slide. If you can just give me a few minutes to walk you through it. This is the global chronic respiratory disease burden and prevalence by country from 1990 to 2017, and then differentiated between females and males. So the light blue is sort of in the middle. The darker blue is a lower preference. The yellow's in the middle as well, but then the darker orange is a higher prevalence. If you look just at North America here for females in 1990, you can see there was a higher prevalence of chronic respiratory diseases in the United States. You look at South America, you got Brazil, and then you look at Asia and Europe, and they're much higher prevalence for chronic respiratory diseases. And then there's good old Australia there. And this is for females. If you compare it down to males, North and South America look a little similar. Brazil is not represented for males, but the prevalence between these two are not that different. If you look at Asia, Africa, Europe, and Australia, males in Asia have less prevalence of chronic respiratory diseases in 1990 compared to females. We go 17 years later, and you can see that the United States up here for females has a higher prevalence of chronic respiratory diseases. The males, Canada has kicked in, but for the United States, the males haven't changed much in their prevalence. For Asia, the females still have a significant prevalence of chronic respiratory diseases, Asia and parts in Europe and Australia, but the males have less, but Europe is still in there. So very interesting differences here where the females are definitely increasing their prevalence in some countries, whereas the males are not. And so we'll talk a little bit about the prevalence of a couple of these diseases. So if we start in the upper left-hand corner, this is airway disease, so COPD and asthma, where the males are in red and the females are in blue. COPD, always thought of as a disease of men until women started smoking cigarettes, and now we're pretty close. Not exactly the goal we want for our female patients, but it's neck and neck. Over at asthma, for adults, males have a lower prevalence than females. Lung cancer. So males here for lung cancer, never smokers, and yes, we have lung cancer in never smokers, less than females. So females are at a higher risk of lung cancer, even if not smoking. For lung cancer related to cigarette, or at least in patients who are smoking cigarettes, the males outpace the females for lung cancer. And then interstitial lung disease, which you'll hear towards the end of this, is a pretty big bucket. There's a lot of different lung diseases that fall under the interstitial lung disease category. But fibrosing ILD, females are a little bit more likely to have it. And then progressive fibrosing ILD, they're about the same. So there's a lot to think about in this, why one sex or gender has more of the lung disease versus the other. So let's start off with asthma. So in asthma, in people under the age of 18 or before the age of puberty, I should really say, boys have a higher prevalence than girls. But once adulthood has hit, 10% of adult women compared to 6% in men. And it is the most chronic respiratory condition in pregnancy in the United States. So for those of you who take care of anyone who's pregnant, who's having some trouble breathing, it's not just the gravid uterus. Think about something else and whether or not asthma is coming to play here. Or if they have a history of asthma, it can get worse during pregnancy, which we'll mention in a few slides. So I forgot to say at the beginning, I'm going to say it here. The literature is very confusing and murky on this. There are some papers that say female males and they are consistent. Some say men and women and they're consistent, but a good chunk of them interchange those terms an awful lot. So I'm trying to use the terminology that was in the papers that I am referencing here. And I think that that speaks to how we need to go forward with research. Women tend to have a more severe phenotype. They are overrepresented in severe asthma cohorts, which means they're more likely to have severe asthma than males. They tend to use the healthcare system more hospitalizations, more ED visits. They're more likely to have the non-T2 endotype. And for those of you who are not masters of endotypes, that means that inhaled corticosteroids don't work as well on them. Inhaled corticosteroids is a mainstay of asthma management. It prevents exacerbations. So it makes sense that those on inhaled corticosteroids trying to prevent an exacerbation, not getting exactly the effect that they should, might be more likely to go to the emergency room and have hospitalizations. Unfortunately, women are often underdiagnosed and less likely to get treatment even when they're diagnosed. They're most likely to get psychopharmacologic treatment like anti-anxiety medications for their asthma symptoms, and then get an increased incidence of asthma around the perimenopause. And we'll talk a little bit about the sex hormones and their influence on that. And then overall, they have a worse quality of life for the same objective measures of asthma severity. So a lot going on in this slide. A lot of things have been identified as areas that make asthma a little bit harder for women, a little bit worse for women, but also areas to target to make it better and to get them better treatment. Sadly, asthma mortality in women has always remained above men with asthma, at least in the 15 years seen here. Males are the light gray bar, females are the dark black bar. The nice piece about this is asthma mortality has gone down over these years, but the women are still significantly above the men, or the females are above the males in this one. You can see how easy it is to switch between the two terms. Females and males were in this paper. So we'll go forward with this, but it's still a deadly disease, and more so for females. So what is the role of the sex hormones in this asthma severity and asthma mortality, et cetera? Well, the European Community Respiratory Health Surveys saw an increase in asthma symptoms in females during menopause, and approximately 40% of females with asthma reporting pre or perioperative menstrual worsening of symptoms associated with an objective measure that decreased peak expiratory flow and increased use of reliever or rescue medications. So there's something about those sex hormones that's causing asthma exacerbations. And this is a great study from 2005, which looked at the different stages of the menstrual cycle. And they looked at ED visits for women who had acute asthma. And they looked at both their symptom onset and how many ED visits they had. And so pre-ovulatory has the highest. So right before ovulation is when a female patient with asthma, or a woman, which is what was said in this study, is likely to have worse symptoms and go to an emergency department. Peri-ovulatory, that goes down. Post-ovulatory is the lowest. And then perimenstrual goes back up again. So that changes in estrogen and progesterone levels is associated with the symptom onset and ED visit. The other thing we know about sex and asthma is there's a clear variation in T helper 2 cells and eosinophilic inflammation with the menstrual cycle. So one of the main things that is associated with asthma in some patients is eosinophils rushing to the surface and causing a lot of inflammation and mucus production. You see increase in sputum eosinophilia in the premenstrual phase of the cycle. And in this study, they reported contraceptive use from a 17-year population-based study in the UK reduced the risk of severe asthma. So controlling those levels of estrogen and progesterone throughout the cycle had a significant impact on patients. And I have to say, until I read this study, which wasn't on my radar until we did this review, I don't know that I've ever thought to give oral contraceptives to a severe asthma patient. I do now. I don't know that that's 100% based on one study that we should change practice, but it's worth considering. Pregnancy is well known to affect asthma symptoms. 1/3 will improve, 1/3 will worsen, and 1/3 will remain stable. And I learned that many years ago, and that has played out in my practice as well. So the sex hormones associated with pregnancy, there's something different about it. And you can't easily predict which patient during pregnancy is going to get worse, unfortunately. On the bench side, some work has been done in mice. So they had overrectomized female mice, had reduced IL-5 levels in eosinophil recruitment after ovalbumin exposure compared to control mice, right? So that eosinophil recruitment to the airways is part of the problem in asthma. Treatment with a synthetic estrogen before the ovalbumin treatment restored the excessive eosinophil recruitment, suggesting a direct effect of estrogen in promoting eosinophil recruitment to the airway. So estrogen, good for a lot of things, but maybe not so good for asthma, or certainly in these mice it wasn't. And then a direct effect of estrogen in promoting eosinophil recruitment to the airway, causing the inflammation, sputum production, et cetera, that we see in asthma. Now here's a tough slide. I'm not going to go through all of these for you, but I like the look of this because it shows you right here the two sex hormones we see in females, estrogens and progesterone. Both of them do an awful lot of inflammatory, promoting mast cell degranulation, histamine release, reducing ciliary beat frequency, so clearing your sputum is difficult. And these that are listed here are mainly pro-inflammatory actions in asthma. Whereas in males, testosterone does the opposite. You get less eosinophil infiltration, less of these inflammatory interleukins, and less mucus production, so mainly anti-inflammatory action. So maybe this is part of the reason behind, the mechanism behind women having an overrepresentation in severe asthma cohorts. Now let's move on to COPD. COPD, when I went through my pulmonary training a little while ago, I was taught disease of a man. Men smoke more than women. They're the ones who get COPD. That is not the case anymore. So this is a look at 2005 to 2014 hospitalizations in males and females, and then in-hospital deaths in males and females with the diagnosis of COPD. The top graph is the same information as the bottom graph. I like the top graph because I think it's easier to appreciate the difference. So if we just look at hospitalizations, the males are the blue line here, and the females are the orange line up here. So every year that was sampled and looked at, the females outpaced the males for hospitalizations. Now, what about in-hospital deaths in patients with COPD? The dotted blue line is males, the dotted orange line is females. Thankfully, the in-hospital deaths have gone down dramatically during that time, but the females are still above the males at every year sampled. So sex and COPD. Women with COPD are more likely to be misdiagnosed, leading to suboptimal treatment. COPD presentation is part of the problem. The women with COPD tend to be younger, smoke fewer cigarettes. So that's part of the problem with thinking about COPD in your patient in front of you. You think it's not that much tobacco exposure, but they do develop COPD with less tobacco exposure, and they have a lower BMI, but they have more evidence of dyspnea. Socioeconomic, the women tend to have lower socioeconomic status than men, those with COPD. And then COPD disease prevention. There's a differential burden of comorbidities in women versus men, where women are more likely to have asthma, osteoporosis, depression, whereas men are more likely to have sort of heart disease as one of their comorbidities. And there's evidence of greater psychological impairment in women versus men. Tobacco use, that's the #1 leading cause of COPD. It varies by location. In some countries, men smoke much more than women. Certainly that was the case in the United States until the 1960s and 70s, when the tobacco companies targeted campaigns advertising specifically to women. And smoking has become equal in some countries. In women with COPD, there's evidence of greater harm versus men for the same level of tobacco exposure. There are greater benefits of stopping smoking in women, but they're less likely to be successful at stopping smoking. Occupational exposures that lead to COPD. Women now actually work in the factories, as opposed to my example at the beginning of the talk, and are exposed to some of these inhalants that can lead to COPD or worsen COPD. And then the non-occupational exposures, which I mentioned worldwide, women tend to be the cooks, and in a lot of places they are using cook stoves. In Boston, where I practice, we have a fair number of people from other countries who are still using cook stoves where they're living. And so they're leaning over the fire and inhaling it while they cook. And it can be a real problem, obviously. This is a slide that just sort of summarizes the clinical presentation differences in COPD amongst men and women. Women have more lung function decline, more exacerbations, more sensation of breathlessness, less cough and sputum, lower quality of life, and this is all controlled for the same degree as COPD. Their comorbidities are anxiety, depression, osteoporosis, and they're much more underdiagnosed. Why is that? Well, one of the things you can think about, it's not the whole reason, but if a patient comes in, doesn't smoke that much, has a history of anxiety, and is saying they're short of breath, or they can't catch their breath, you may not think as seriously about it as if another person comes in, smokes a lot, has a history of heart disease, and says they can't catch their breath, right? What are our triggers in the medical community? Heart disease, we've got to prevent the heart attacks. What else could be going on? They're more like, men are more likely to get worked up a little bit more than a woman who's going to get an anxiolytic. And then there's a bunch of work that is just starting to come out on omics, genetics, epigenetics, transcriptomics, metabolomics, proteomics, and networks. The third, I'm not going to go through all of this, but over here, this last slide here shows what we really need to advance the field, and there's a lot that still needs to be done for sex and COPD. We know a bit about it, but much more detail to come, especially, unfortunately, since women are still smoking and we have not really made great inroads in that. And the consumption of tobacco smoking is projected to increase in females. Women may have a heightened susceptibility to the lung damaging effects of smoking. And estradiol is known to upregulate P450 enzymes, making the female lungs more susceptible to oxidative stress. So we're getting there on the mechanisms. And we know smoking cessation can be helpful in a lot of conditions, reduces the lifetime risk of lung cancer as you go away from the last time you smoked, you have more time, but also with COPD, prevents the progression to some degree. But women are less successful. So the CYP2A enzyme is induced by estrogen, leading to quicker metabolization of nicotine. There's availability higher in male smokers of some other markers, and then more vulnerable relapse during the follicular phase. There we go again, those sex hormones. The low progesterone phase is when women are likely to start smoking again, or females are likely to start smoking again. Women have been targeted, so this is a very young audience, but those of you with a little gray hair might remember the Virginia Slim cigarettes. Virginia Slim cigarettes were these, they made them nice and delicate looking, and they came out in the 60s or 70s with an ad campaign saying, "You came a long way, baby," meaning that women could now smoke in public. And it was targeted right towards women to increase their smoking. There were a lot of other campaigns, but that's the one I remember so clearly. Women are less likely to stop smoking. When they stop smoking, they have a higher relapse, and depression and weight gain are identified by patients who are surveyed as a barrier to stopping smoking. There is some benefit to pharmacotherapy to help with smoking cessation, so we are making some inroads. Now moving on to lung cancer. There is an epidemic of lung cancer in women in the United States. The WHO estimates 600,000 women died from lung cancer in 2019. In 1987, lung cancer became the leading cause of cancer death in the US women, and it has not changed or remains so today. I know next month is Breast Cancer Awareness Month, and we will see pink everywhere. I almost never see anything about lung cancer as far as public service announcements and awareness of the public. Globally, 53% of women and 15% of men with lung cancer are never smokers. right? Because women have other exposures. It might not be cigarette smoke. They have the biomass fuel, et cetera. In the US, it's 15 to 20% of women with lung cancer were never smokers, as opposed to 7 to 9% of men. There is a larger reduction in mortality for women when screened routinely, but our criteria for screening for lung cancer is the low dose CT, which includes years of smoking and the last time you quit. So for never smokers, you have to really justify, I have not been successful in this, and we don't have guidelines yet to say exactly how to screen women who don't smoke for lung cancer. And like I said before, cigarette smoking is the leading risk factor for lung cancer, but there are non-smokers getting lung cancer as well. And this is another great slide or picture that I think really drives this point home. This is from the World Health Organization showing sex and cancer, females greater or equal to the age of 30. What is the expression of these cancers? Blue is lung cancer, pink is breast cancer. And you can see in the United States, it's lung cancer. And it's increasing, it has increased to the level of an epidemic. China, parts of Europe, and Australia, lung cancer outpaces breast cancer. The rest of the world, breast cancer has a big hold on many of the large populated areas. And then this is cervical cancer here in Southern Africa. A very interesting graph there. So overall, sex and gender and lung cancer, women have a higher likelihood of having the adenocarcinoma type of lung cancer, higher likelihood of activating mutations in EGFR, higher domestic radon exposure, right? So back to what I said before, gender roles, women tend to be more in homes. And so if they have a high radon level in the home, especially people with a lower socioeconomic status who may not know to get it tested and get the radon out of the house, they can have radon exposure leading to their lung cancer. Higher likelihood of misdiagnosis or delay in diagnosis. If you can't screen for it, if you can't get the CT scan approved to screen somebody who you know is using a cook stove or knows they stay in a house that maybe has radon, maybe doesn't, you can't find it until they have significant symptoms like hemoptysis or chronic cough, and you eventually work that up. The good news for women is that a 5-year survival for all types of lung cancer, all stages and all treatments is better than men. And if you look here, this is just a nice graphic again. Men have overall increased mortality and worse tumor grade at diagnosis, but they do have a better response to the immune therapies. Women have a decreased mortality and increased response to the EGFR inhibitors. And then this is a nice graphic showing sex hormones affect anti-tumor activity, therapy-induced death, and lung cancer cell proliferation. Now on to interstitial lung disease. So like I said, interstitial lung disease is sort of a bucket term for a lot of different diseases that can affect the interstitium in the lungs. We'll start with idiopathic pulmonary fibrosis, previously thought to be only in older men. After the age of 65, male person with fibrosis seen on their CT scan in their lungs, you think IPF most likely compared to the other ILDs. Women tend to have a lower prevalence and a better prognosis with IPF, lower rate of hospitalization, and the question is whether or not IPF is associated with short telomeres. The telomeres at the end of the DNA shorten over time. Women are thought to have possibly better telomere length, giving them better outcomes. And then the treatment we use for this is to slow down the progression of fibrosis with antifibrotics. Both genders seem to have similar responses to that. Connective tissue disease related ILD. So women with lupus, systemic sclerosis, and Sjogren's have a higher prevalence of this ILD compared to men. And the highest sex-associated connective tissue disease ILD is in women with lupus, 7-to-1 compared to men with lupus. So big difference there, but less overall fibrosis. And then a few more comments on these. Rheumatoid arthritis, lower prevalence in women, less aggressive disease and less mortality. So there is definitely a preference. Women do a little bit better with ILD for some of them. I'm going to, in the last couple of slides, go over a few things just sort of very briefly that I wanted to mention, but putting in a bunch of slides on them would have made this talk too long. You can't do a respiratory talk on sex and gender and lung disease without at least mentioning cystic fibrosis and non-cystic fibrosis bronchiectasis. Females compared to males have a lower survival in CF. The increased estradiol is associated with earlier bacterial colonization in CF, which is one of the things that leads to significant morbidity in these patients. Like asthma, their menstrual cycle is associated with exacerbation. So for CF and non-CF patients with bronchiectasis, there's higher exacerbations during the follicular phase. And then fertility in females below expected, and then males are sterile because of the dysfunction. Gender differences in CF. Women with CF tend to have a lower quality of life and a greater emotional impact of that disease, worse body image, a lower BMI, more frequent exacerbations, and a more rapid decline in their lung function. Symptoms and disease characteristics in non-bronchiectasis are more common in women. There's worse lung function in women, and it presents earlier. And then overall management, there's lower treatment adherence, unfortunately, in women in CF compared to men. But treatment efficacy equal in non-CF bronchiectasis, but women note less meaningful improvement by questionnaire. So our eyes look like the treatment is being efficacious, but they don't feel it. A very different subjective component of that condition. This is a nice summary of what I have said thus far, just to give everybody just a quick review before I start wrapping this up in the next few minutes. Men tend to have a higher prevalence of COPD, but women are close behind. There's a higher prevalence for men before puberty for asthma, but after puberty, women outdistance the men and have higher mortality. Lung cancer incidence and mortality is higher in men, but there are some studies saying that they respond better to immune therapy. And IPF is more common and mortality is higher in men than women, or in male sex than female sex. Some of the reasons behind it are for COPD, the targeting of women for cigarettes and increased smoking rates, occupational exposures for asthma, as well as the menstrual cycle component for asthma. And then the symptoms through all of these, females tend to have more subjective symptoms for the same severity of disease for all of these. And then this, a condition that is unique to one sex, the pregnancy. And I won't go through all of this, but pregnancy affects chronic respiratory diseases and also can predispose to other respiratory diseases. So there's a modified immune response in pregnancy, leading to some infections. There's a hypercoagulable state, so pregnant patients more likely to have blood clots, pulmonary embolism. Women are more likely than men to develop some forms of pulmonary hypertension, pregnancy being one of the conditions that increases that risk. There's teratogenic effects of some drugs, and there's teratogenic effects of radiation for some. So if somebody's undergoing cancer treatment with radiation and they're pregnant, that's a whole different thing to deal with. And so when you do have a pregnant patient and they are having some trouble with their breathing, it can be a pre-existing chronic respiratory disease, but it can also be the condition of pregnancy that is increasing the risk of having that. And like we said before with asthma, a third will get worse, a third will get better, and a third will stay the same with their asthma. So if we go back to our questions that I asked at the beginning of this, what sex presenting with asthma symptoms is more likely to be prescribed psychopharmacologic agents rather than inhaled steroids? And the answer is female. Between 2005 and 2014, what sex had the highest proportion of COPD hospitalizations and in-hospital deaths? Female. Which cancer is the leading cause of cancer death in the US? Lung. And what sex is more likely to develop idiopathic pulmonary fibrosis? And that is males. So my final thoughts on this is, after a couple decades of looking at this and reading about it and putting together talks and reviews on this topic. Sex and gender are biological variables important in every aspect of the patient experience. The symptoms. Someone comes in, like I said, shortness of breath, but they have a history of anxiety. They're female, less likely to be thought of for asthma, right? And more likely to get a benzodiazepine. Screening. Women tend to have a higher prevalence of non-cigarette smoke lung cancer, related lung cancer, but we can't get the screening low-dose CT approved for them. Diagnostic testing, like I said, the low-dose CT. Women with asthma go for a long time being treated with their anxiolytics before anyone does spirometry on them. Whereas men with the same type of symptoms, without the history of anxiety, are more likely to get spirometry pretty early in their shortness of breath. Treatments have to be very targeted. We have a lot of work to do on this. There are some areas where the treatment is equal, but like for asthma, if you have that endotype where the inhaled corticosteroid doesn't work as well, that can lead to more exacerbations and more severe asthma. And then outcomes, you could see with asthma that we still have a lot of work to do to get the women's asthma deaths down closer, or even both groups lower in asthma deaths. And same thing with COPD. From that study that I showed you, we need to get the women's hospitalizations and deaths down much lower. I think, and I'm very biased because when I went to Brigham 10 years ago, we started the lung center, and part of that was a women's lung center where we had people from all different specialties related to lung disease who were coordinated to see the female, or we use the word woman, patients who are on top of this literature. And we're thinking a little bit more about it. I think that coordinated care, women's lung centers or health centers are critically important for identifying these conditions early with people who have a specialty in it. It's like specialty care, and they have care pathways, which would reduce some of the disparities I've mentioned, and I hope overall improve the patient experience and outcomes. With that, I end. Thank you.
You for a very important, timely, and impactful discussion of these very, very important issues. Just first, a question for clarification, and then a question that I had. In the use of oral contraceptives or oral estrogens in your perimenopausal or postmenopausal female patients, you said that you give it to them. You're more likely now to give them, provided there are no other.
Think about it. I'm more likely to think about it as an adjunct to therapy, right? Whereas before I would never have thought control the estrogen progesterone levels. But now I'm sort of getting convinced that maybe if they keep having these exacerbations, I should start thinking about it.
So maybe it's the fluctuation of the estrogen rather than the absolute.
Correct. Yes. So that's what that one slide showed, that the different stages of the menstrual cycle had different prevalence. Yes.
Yeah. And of course, there's the other LH-FSH component, which.
Correct.
Anyway. Okay. So then my question is, and you can say, well, Roy, this isn't really a pulmonary disease, but I think some pulmonologists, pulmonary artery hypertension.
Yes.
Which is like 9 times more prevalent
Correct.
in women.
Yep.
Than female. Do we learn anything from that in terms of mechanisms of disease that would be helpful for us to apply to some of the other pulmonary diseases?
Sure, I could talk about an hour on that. So women, a higher risk of pulmonary arterial hypertension, certain classes of it, obviously. And we do think that the sex hormones are deeply involved in this. It's not necessarily gender. It's not necessarily exposures, although that hasn't been fully teased out. And so I do think that's a whole nother lecture on that. There's tons of literature on it. But again, you get a woman of reproductive age who's saying they're short of breath or they have dyspnea. Start thinking about these pulmonary conditions. And where I work, a lot of people think pulmonary hypertension is a pulmonary disease.
Yeah. You ask the people here, they would say the same.
Yeah.
Any questions from the audience before we get to the those Dr. Danica.
It's a little murky.
Repeat the question.
Yeah, so the question was, after the age of menopause, because of the drop in estrogen, do asthma symptoms and exacerbations change or reduce? The literature is a little bit murky on this, and they've looked at some studies with giving, so the women who are given hormone replacement therapy versus those who didn't, the one with the hormone replacement therapy tended to have more exacerbations, but these are small studies, so I don't want to say anything as an absolute.
Was there another question? Okay, go.
Yeah, great. Right. Great question. So is whether or not, given some of the conscious or unconscious bias with patients with dyspnea or chronic respiratory diseases between women and men, do these women centers or these women lung centers, is there data showing that they improve patient outcomes? I think we're yet to see a massive impact, but subjectively, certainly subjectively, the patient surveys are they're much happier in that regard. And but the problem with the lung centers, by the time they got to us, they already had the diagnosis. Someone had already given them spirometry, started them on inhaled steroids. So we did not have primary care providers initially in the Women's Lung Center. Then now in the big Women's Health Center at Brigham, they are now trying to coordinate all of that specifically for that reason. So you have the front line saying, wait a minute, this might not be an anxiety attack. This might be an onset of asthma.
Dr. Punjabi.
Yeah. Right. Yep. Yeah, so it's a great question. In the humans,
Repeat the question.
oh yeah, the question is, what do we have in regards to transgender? Because the patients that are transgender and transitioning get exogenous sex hormones, right? And so what happens if I give a mouse testosterone, take out their ovaries and give them testosterone, or vice versa? We have, at least for asthma, we have a pretty good idea of the exacerbation and the sex hormones evaluation within that realm. In humans, we have almost no data of what's happening with these patients, at least the respiratory diseases I've presented here today. It is an absolute dearth. I know people who are looking at this and publishing on it. We have small studies. Obviously, we don't have a lot of patients yet doing this transitioning and getting these exogenous hormones for a while. I mean, there are some things that we do know, right? Estrogens increase your risk of breast cancer. Testosterone increases your risk of obstructive sleep apnea, other conditions. But what's happening with asthma? I would imagine a female getting rid of their estrogen, progesterone, and getting testosterone, their asthma might get better, but I don't have a big cohort study to tell you that actually happens, right? I look at this slide and I say, oh, well, maybe that will change. We also don't know what to do with some of their diagnostic testing. So for those of you who don't do this, pulmonary function tests are based on male-female normative data. What do we do with one who is born female, transitions to a man? They're getting testosterone, they're getting bigger muscle mass, but their lung size wouldn't necessarily change, right? So their female lung is smaller. So what do we do with it? Is there normative data? We don't have it yet. Yes. Yes, it is. Sure. So the question is, yes, the question is pulmonary is a very male-dominated specialty. I agree with that 100%. And do female patients do better or worse with a male pulmonologist or a female pulmonologist? It has not been drilled down to that degree yet, but the big studies that have shown that patients overall do better with a female doctor. And I think that might be skewed because of the women in the patient population, because I do, at least in my career, I cannot tell you how many women patients have cried in relief when I said, this could be X, Y, or Z. And they said, you're listening to me. Not to say anything bad about my male colleagues. I love them. They're all very good, but I think there might be, you know, if I were a guy and I didn't know the data that I just presented and some woman says to me, oh, my asthma is always worse, you know, right before I get my period, they were like, okay, all right, right? But if you haven't read the work, you might not know that that actually is a thing.
Last question online, Dr. Marcus, if you can unmute yourself, you can ask your question, please.
Sure. Thank you. Thanks for an excellent talk. It was really, really interesting. We take care of a lot of patients who are involved in housekeeping. And I was wondering if you could talk about the role of exposure, chronic exposure to cleaning materials in COPD risk.
Sure. So yes, cleaning materials, I didn't even list them here, but absolutely. So we know some of them with ammonia can exacerbate any respiratory condition. Who knows what they're using in some of the cleaning supplies, right? A lot of these big corporations that have this industrial cleaner can increase the risk, not just to COPD, but also like some of the interstitial lung diseases and other chronic respiratory conditions. And so again, it really depends on what your occupational and environmental exposures are for some of these conditions and what worsens them, and whether or not your gender identity puts you in one bucket. I mean, the interesting one that I remember from my training is the men working in the shipyards blowing asbestos. They come home, their wife washes their clothes, and the wife gets the mesothelioma because she's shaking it out, and right, whereas they had a mask at work. So we really have to delve deeply into a lot of these. There's so much more work to be done in this area. So I thank you so much for your attention.
So I just, as a plug, we do have, started a year and a half ago under Dr. Morgan Sendish-Ushane, the Women's Health Alliance, where we have female providers from all different subspecialties taking care of specifically women with all sorts of medical problems, and one-stop shopping, so to speak, for women and their health needs. And if you aren't aware of it, just look it up on our web, and you can refer patients to them. They have openings all the time, and it's our attempt to close the disparity gap, specifically in these areas that we just heard about. Well, thank you for an amazing grand round.
Thank you.
Just wonderful.